Alright, pharmaceutics of drug delivery systems. We looked at reactions, rates, orders, those types of things before. And as part of drug delivery system design, that kind of information is then gathered, utilized, and applied in constructing an appropriate drug delivery system. In fact, even in choosing appropriate drug delivery systems. And the ingredients in a formulation would be picked to facilitate our drug getting to where it needs to go. Here we will look at focus more on that process where our potential drug delivery system is going to interact with a biological system and utilize the factors of biopharmaceutics and pharmacokinetics. Now, biopharmaceutics in and of itself is a subset of pharmacokinetics. Pharmacokinetics is the entire gamut of this particular science. Biopharmaceutics is the drug delivery system interacting with a biological system. So, definition, you've seen this before. So the drug delivery system is what we put our drug into to deliver it to a patient. Part of the thought going into choice of this is to try to make it as easy, as simple, as straightforward as possible for lay individuals, for the patient to administer a drug. You would not directly go too complicated. Yes, there are some preparations out there that have to be injected, but that's because there's no other route that it could go in. You want simpler. Part of what also goes in here, and I'll mention it maybe from time to time, is also cost. What's the least expensive way to do it? Obviously, EpiPens are not the least expensive things in the world to make. But that's because of their complicated drug delivery system and the fact that the drug itself is not all that stable. So you sometimes do the best that you can. Jacking up the price 600% over the past 8 years, I've got no comment on that. Now, I will bring up, and I'll be forthright, this is a pet peeve of mine, a pet professional peeve, if you will. And since I'm the professor, I can express that. The term pill. I get a rash every time I hear it. It is not a generic term for drug delivery system. Tablet is not a generic term for drug delivery system, nor is capsule. What's the difference between a tablet and a capsule?
Round versus oval. Round tablet. Capsule.
A tablet is made by compression.
Capsule.
A capsule is inside some kind of gelatin shell. There are actually multiple kinds of capsules, and we'll talk about those. So if tablets and capsules are not the same, a pill is a very specific drug delivery system that is made by hand, by rolling. It's usually rolled into a little ball, might be a little ovoid, and they're made by pharmacists. There really is no device, no mechanical device that can make these. So they have never been manufactured. They've always been just compounded. And in olden times, back in late 1800s, early 1900s, that's actually even before my time, believe it or not. One of the ways that they were treated to make them easier to swallow is they might have been coated with a small coating of powdered silver that would make them easier to swallow. Tablets and capsules aren't made that way. So though a pill, there is such a thing as a pill. Definition, a medicinal substance in a small round or oval mass that's meant to be swallowed whole. our modern day dosage forms, none of them fit that classification. So inappropriate use of the term pill could qualify you to fail this course. That's how serious I look at this. So don't use pill incorrectly, which fundamentally means pretty much stay away from it. Trying to educate you properly and encouraging you to use wrong terminology about the drug delivery systems doesn't help. Pet peeve time over. You will be happy to know up to this point in time, I have yet to fail someone for inappropriately using the term pill. Don't break that record. Please. I don't want to do that. Purpose of a drug delivery system, you can see here. For the patient to self-administer, but we also have to take into account, well, the drug has to be stable for a long enough period of time. We talked about some of the stability issues, so we would build in excipients to help make it stable. One of the ways to avoid things like oxidation and hydrolysis is to put it in a solid form and coat it to exclude air and moisture from contact. Taste masking. A medication does not have to taste bad to be good for you. Most of them straight, unfortunately, do seem to taste bad. So one of the things is we want to make it more, there's a generic term called pharmaceutical elegance. That means it looks good, and when it's administered, it doesn't cause the patient to make a really bad face or throw up. So pharmaceutical, so taste masking might be in there. That can sometimes be accomplished by the same thing. That's one of the reasons why many things are in capsules. They're easier to swallow, and also the gelatin itself, pretty tasteless, it masks what might be inside. Even a tablet, when you're in the act of swallowing it, some of it can dissolve out and you can taste something. So a coated tablet would get around that, although that's more expensive. It's more expensive to make a capsule than it is a tablet. Tablets are the cheapest, easiest drug delivery systems to make. That's why there are so many of them. You may need to modify the administration, and the future is drug targeting. Right now, when you take something, it pretty much goes everywhere, and you have to give a sufficient quantity such that sufficient amount gets to where it needs to go. But it goes elsewhere. When it goes elsewhere, that's where side effects come from. If we can target it, if it can go just to the site of action that it needs to go to, we can give less drug and have less side effects because it's not going other places, activating other receptors. That is becoming increasing lines of research. Been researched for probably the last 30 or 40 years. It's really difficult to achieve. But once that's more achievable, then side effects and drug interactions and those types of things may be a lot less to deal with. So we'll talk a little bit about that, but not as much because there's not as much available. Route of administration. How do you give a drug? And I'm not talking about tablets, capsules, solutions. That's not route. That's drug delivery systems. The route can be classified as two types: extravascular or intravascular. Intravascular is you introduce it directly into the bloodstream. There is no absorption step, because all the absorption process is to get it into the bloodstream. If we put it in there first, no problem. Anything other than directly introducing it into the bloodstream is considered extravascular. Even some, have you heard the term parenterals? You heard the term parenterals. Parenterals, you think of injections, right? And when you think of injections, you probably think, well, all those directly introduce things into the bloodstream. Interestingly enough, about half of the routes that are injections do not go directly into the bloodstream, and in fact do have an absorption step. So this does not mean extravascular means oral and intravascular means injection. No, doesn't work that way. There's a lot of other things in extravascular and not nearly as many as you think in intravascular. Now you will see IV as, into a vein type of abbreviation. Here I'm using it a little more generically because I would consider an intravascular administration to be into an artery also, which isn't all that common. If you have seen an injection into an artery inadvertently, you will understand why, because there's a nice little pumping action of red fluid out of it. Part of my research was doing administering drug to pregnant sheep and measuring it coming across the placenta, and we had to do a surgical technique on the sheep to prepare the samples, and occasionally I would nick an artery and get blood spattered, all over. I had surgical gown and all that kind of stuff on, but I had a nice squirt of blood all up and down. Once you see that, you understand that. So two routes, two main routes. Everything else is a subset of one of these two routes. If it has an absorption step, it's extravascular. If it doesn't have an absorption step, then it's intravascular. So routes of drug delivery. So what I'll do is I'll give you a space and you'll reproduce this chart entirely on an exam. Okay? You good with that?
No.
I got one no. Any more no's? Who votes no? Who votes yes? Who would please stick up your hand that didn't vote because they don't know what we're voting for? Because you just woke up. The coffee finally kicked in.
Oh, yeah.
No. Once you're through this class, once through this semester, you could probably sit down and construct 95% of this, just from memory, just from your pharmacy, what I refer to as your pharmacy common sense. But it's sort of I actually borrowed this illustration from somewhere on the internet, but I didn't like it, so I changed it some. Which is okay. So here you have IV, intravenous injections, intraarterial injections go directly into the systemic circulation. No absorption step involved. So that's your intravascular. A couple other routes that can be put in there. These are the other, this is the part that it didn't have that I added. These are the other parenteral injections. Subcutaneous, intramuscular, intraperitoneal, intradermal. All of these, to get into systemic circulation, would require an absorption step. Now, in some cases, there may not be an absorption step necessary because it's not going to end up in the systemic circulation because the site of action is where it's administered. So administration site, but eventually some of it might get in there. So it goes to the administration site, which may or may not be the target tissue that's there. Then you have the other extravasculars. Oral delivery is probably the principal category that you would think of. Well, when things are absorbed, and we take advantage of the GI tract. Your small intestine, its main function is absorption. It's designed for absorption. It's designed for absorption of nutrients. It's not really designed for absorption of exogenous chemicals, of drugs, but we take advantage of that. So oral administration is going to go through the absorption designed organ of the body, which is largely the small intestine. Talk a little bit more about that later. Now, when things are absorbed into the body has somewhat of a protective mechanism. All of the blood, except for the very lower part of the rectum that goes to the GI tract, even the colon, first flows through the liver before it goes to the rest of the body. The liver, as you recall, is one of the significant organs of drug elimination because of its biotransformation pathways. There's even some excretion pathways there. So when we design our drug, and if we're giving it orally, and it's eliminated by the liver in a significant fashion, we may have to add extra drug to it, to our dosage form, to make certain that enough gets by the liver so that it can have a systemic effect. This is referred to, and you'll hear this if you haven't already heard it, as first pass effect. Because it gets absorbed, it goes through the liver gets first shot at it, it's at its highest concentration it's going to be in the body, so it's pretty efficient. And in some drugs, they can't be given orally because the liver is so efficient at eliminating them that the first pass pretty much eliminates all the drug. So even though some drugs might be absorbed, that's not the reason they can't be given orally. It's because their first pass effect is so substantial, we can't put enough drug in there. It's like, okay, well, if you take your dosage form this large, that might be enough, but obviously that's not possible. So the liver eventually this goes into the systemic circulation. Topical delivery. Topical, usually our target is local, is the skin area. So that's our target tissue. There may be some drug that gets into the systemic circulation, but that's not where we intended it to go. If you have a rash, you put hydrocortisone or something on it, it's a local active. As opposed to transdermal, which the skin is a barrier, and it is designed for systemic administration. So how you would formulate those two things would be very different. So in a topical delivery, you just want it to work locally, so you're not concerned about drug penetrating the barriers of the skin. Whereas in transdermal, you are. And then here's a variety of other types of administration, which are under the general category of mucosal delivery, because they're basically placing the dosage form on some tissue mucosa, top of which has usually a layer of some type of local mucus on it. So the eye, in the nose, in the lungs, in the mouth, in the rectal area, in the vaginal area, there are a variety of drugs that are administered in this way. The urethra is even an avenue for drug administration as well. All of these, some of these might be for local actions, but if they're systemic actions, then they would have an absorption step. So each of these dosage forms, we can't design one dosage form and then deliver it all these different ways. Just not possible, not feasible. So each dosage form has its own particular attributes. And during the course of this semester, we will talk about each and every one of them. Now we will spend the most time on tablets and capsules because those are the ones you most encounter. tablets and capsules, and then we'll talk about some liquid dosage forms, talk about solutions, emulsions, suspensions, etc. Included in this particular class might be some demonstrations of how to appropriately or inappropriately make some of these drug delivery systems. So this is just kind of give you an overall view of the various and sundry drug delivery systems. So you have a drug, you know its target organ, then you have to decide, all right, which of these drug delivery systems is the most appropriate for administering this particular drug. And keep in mind, you want to make a drug delivery system that is the least complicated and the least expensive to make, is stable for the longest period of time, and is the most adaptable for a variety of patients. Because after all this is considered, then you have to think of, is this for an infant? Is it for a pediatric patient? Is it for a geriatric patient? Is it for a regular adult? I'm somewhere at the borderline of the geriatric regular adult at this juncture. So there's a lot of factors that go into here. And we'll peripherally talk about some of them. We can't go in depth about all of them unless I did 16 credit hours over the entire semester. Which would be really interesting, but couldn't fit that in. So choice of drug delivery system depends upon where does the drug need to go. Where does the drug need to go? We'll have to take into account, mention this time to time, the anatomy and physiology of the body as well in determining which drug delivery system to pick. So is the target local? Is it systemic? What route of administration? Is it extravascular or intravascular? Most often, those drugs that a pharmacist will see and dispense in a community setting are going to be extravascular, by far. At one time, that was the only thing you saw except for maybe insulin. Now we have an increasing number of self-administered intravascular preparations. Although I mentioned the EpiPen thing, that actually goes into a muscle, so it does have an absorption step. So pharmacokinetics and biopharmaceutics. Definition. And this is adapted from definition that's in your textbook. Study and measuring, and I added by estimation because we make some assumptions of the rates of reactions or processes of the drug. And the reactions and processes is what falls under the general term of kinetics. So looking at these processes and reactions are kinetics, so it's timed. And it's those things that we've seen before: Ladmer, liberation, absorption, distribution, metabolism, excretion. Combined, they make up elimination, and response. That's pharmacokinetics. Biopharmaceutics is the subset of that, involving the physical, chemical, biological processes involving drugs, drug delivery systems, drug action, and their interactions with a biological system. So biopharmaceutics deals with how much drug to put in, where it's absorbed, how it's administered, what drug delivery system, all that type of thing. So generically, this whole discussion could just be done under the title of pharmacokinetics, but because biopharmaceutics is often broken out as a subset, I wanted you to be aware of that. So how it's looked at, the mathematics, the assumptions are the same within these two situations. So what you would need is information about the drug's interaction with biological systems in these particular areas. We need to know how much drug to put in there based upon how much actually gets in. And once it gets in, how much of it potentially reaches or needs to reach the target site. Understanding that by and large, our drug doesn't go just to the site we need it to, it kind of goes everywhere. So in order to get sufficient at our desired target, we have to add enough such that when it spreads around, it gets everywhere. Again, unfortunately, that's where side effects tend to come from. So expound on each of these. Liberation. And we'll talk, sort of bring up some things that we've already talked about. Drug that is not already in solution, especially that has an absorption step, needs to get it into solution before it can be absorbed. So the choice of crystal form of the drug would be a factor in that. It's not just, okay, this drug molecule does this, and we had that discussion already. So choose the most appropriate crystal form. Now here, this might be, as with many other things, it might be a compromise. Crystal form C, whatever that might actually be the most soluble, the best, etc. But it may be so expensive to obtain that the price would be prohibitive. Although to think of any drug company saying, well, no, that's too much to charge as a consideration, seems a bit out there, but believe it or not, that will go into it. Or maybe more appropriate, it might be, it's just difficult to make. It's really expensive because it's difficult to make. So it might be a compromise that crystalline form E has a lot of similar properties. It's almost as good, not as good, but is half the price or less than half the price because it's easier to make. So it'll be choices like that that will go into that. So it's not always what might actually be the best. It's the best given other competing circumstances. Excipients are chosen to facilitate these types of things, maybe getting the drug to release, maybe keeping it stable during storage. This is where if the drug oxidizes, there might be an antioxidant as one of the excipients in there to make it more stable. Also depends upon the intended release pattern. We will focus, when we start talking about tablets and capsules, we will focus initially on them being immediate release. Immediate release means once it's ingested, then the intent is the drug goes into solution as quickly as possible and is absorbed as rapidly as possible. That's immediate release. There are other drug delivery systems, tablets and capsules, and other types that fall in the general category of modified release. Now, in this class and in many other places, modified release is a general encompassing term, which relates to anything that's not immediate release. So that's the way that I will use it. You will see it used in other ways, and we'll talk about that when we talk about modified release. But what would fall under modified release, there's a bunch of things here. Delayed release, controlled release, extended release, blah, 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 blah. And there's a lot of overlap between these terms. There is not universal agreement as to what each of these individual terms necessarily means. But I will defer that talk until we talk about modified release. So right now we just talk about immediate release, modified release, where your selection of excipients depends upon which way you're going. It's a lot simpler to make an immediate release preparation than it is a modified release. Modified release tend to be more complicated, tend to be more expensive because it requires more and different types of excipients. And the type of drug delivery system that you choose depends upon how much drug you have to include. If a drug is very potent, potency on a drug relates to how much drug do you need to give to see the desired pharmacological effect. The more potent it is, the less that quantity is. There are some drugs in their delivery systems that are in there in microgram quantities. Then there are other drugs that require almost gram quantities. So what dosage forms you can incorporate them into is limited by how much drug you need for a given dose. And in fact, if the dose is high enough, you may not even be able to prepare a modified release preparation because it would be too big. Again, we'll talk about that later. So immediate release, we're going to put things in it such as things that will cause it to break apart or disintegrate. So that's a disintegrant, believe it or not. But there are also ingredients that help it to flow over the processing machinery efficiently. Absorption, choice of chemical form again, which is the more soluble, which is the more water soluble. And this may have to deal with pH as well, whether it's ionized or unionized at biological pHs. So we may have to add ingredients to alter that. Excipients may be chosen to help it go into solution. A surface active agent or a surfactant may be added to facilitate it going into solution. Mechanism of absorption might affect the choice of drug delivery system. Most drugs absorbed through the GI tract are absorbed by passive diffusion in a first order fashion. So the larger concentration in the GI tract pushes the drug in to the bloodstream. There are some mechanisms where there may be carriers involved. Might be active absorption, might be facilitated absorption. And these change the type of drug delivery system that we might choose to use. Might also alter the amount of drug. Any route-specific issues, so not just oral, but if this is to be administered, rectally or transdermally or something like that, there's always local issues that have to be addressed there. The mass of the drug that gets absorbed. So here's where, and apparently my arrows got off here a little bit. But the bioavailability of a drug is expressed by the term F. Because this is determined by a ratio, it has no units. So if F is 0, that means no drug gets in. No drug reaches the systemic circulation. Doesn't necessarily mean no drug gets absorbed, but it might mean that the liver takes it all out. Up to F equals to 1, which means all of the drug gets in. Usually we're somewhere in between there. If it's at least, believe it or not, 30 or 40% or more, then an oral route is acceptable. There are even some drugs that have been on the market a while that their bioavailability is somewhere around 0.1. Furosemide, Lasix. An oral dose of Lasix, a standard oral dose of Lasix, is 40 milligrams. A standard injected dose of Lasix, 1 milligram. Its bioavailability is awful. But enough gets in. So how much drug we include in that drug delivery system or need to include is partly determined by F and everything else. So a lot of factors to consider. Distribution. Where does it go once it gets in? Now here is where our choice of drug delivery system kind of fails us. Once it's in the body, how the body handles it, our drug delivery system is now kind of out of the picture. We just needed to get it in there, and then what the body does to it is almost out of our control. Changing its chemical form somewhat can affect it. You have heard of prodrugs. That doesn't mean they're professional drugs. That means that they in and of themselves likely don't have any biological activity or very limited, but they're converted to the active substance in the body. So that might be something that we could do. Make something that's more absorbable, and then it's converted to its active form, where the active form is not all that absorbable. So how the drug moves throughout. Also binding to blood products, such as blood proteins, albumin, alpha-1 acid glycoprotein, those types of things. Affect its distribution, either positively or negatively. So slight structural alterations may affect that binding. Trouble is, when we make structural alterations to a drug molecule, we have to make certain we don't negate its activity. Mechanisms of transport pathways. Once it's in the body, to get out of the bloodstream into various and sundry organs, we can again counter largely passive diffusion, but also some carrier-mediated transport processes. And the distribution pattern also determines the mass of drug necessary to put into the drug delivery system. If it goes everywhere, we may need to put more drug in. If it's a very lipid-soluble drug, we may need to put excess because of the adipose tissue in most patients. It might migrate into the adipose tissue, and that's not the active site. Sir?
Can a body adapt to the drug and develop tolerance over time?
That is something that could be a consideration, but it depends upon what the mechanism of the tolerance is. So that would be something, remind me and I'll make certain I address it under response. But it could also be here under metabolism. The tolerance that develops could be that with time, the drug actually induces its own elimination. So it stimulates its own metabolism. So it could be biotransformation, could be tolerance. Now I know the tolerance you're thinking of is actually something else more on effect. The only way to deal with that is to give more drug. So you would have to increase the dose. You wouldn't necessarily design a specific dosage form to deal with those that are tolerant. Too much chance of an overdose for those that aren't. Metabolism involves structure and chemical attributes, some of those processes that we talked about. Most metabolism, biotransformation, and again, those are not exactly the same terms. They're used as synonyms, so I'll just follow along with that. So enzymatic system, so largest variety are in the liver. Second largest variety of biotransformation pathways happen to be in the lungs, interestingly enough. So the lungs as a clearance organ are often not thought of. and you can actually have the equivalent of a first pass effect on an injection, because everything that's injected into the veins will then first pass through the lungs before it gets to the rest of the body. Although the different number of biotransformation systems in the lung don't rival the liver at all. Biotransformation, so we can do some things structurally. You can also give other ingredients, non-therapeutic ingredients that might block or alter that biotransformation pathway. Excretion has to do with structure, chemical attributes, especially solubility, because most excretions are done as a result of it being water soluble. Some biotransformations convert drug molecules into something that's more water soluble, and then that's excreted. Sometimes this might be a conjugation reaction. That conjugation puts this large water soluble group onto the drug molecule, and then it's eliminated. When that happens, when it's eliminated, especially if the route that happens is in the bile, it dumps it back in the GI tract. That group could be cleaved off, and your drug is now the drug again, and it could be reabsorbed. That's enterohepatic circulation or recirculation. So you can see an effect of drug. Even you can see like 2 peaks of drug after a single administration because it's recircling through the body. pKa of the drug can be a factor in this process, so kind of altering its salt form might affect the elimination. The lifestyle of the patient might affect excretion of a drug, and I mean from the standpoint of dietary. Most people are omnivores. They have vegetables and meat, and the pH of the urine tends to cycle between about 2 and 6. Those that are vegetarians, their urine tends to be around 5 to 7. So the excretion pattern of some drugs can be significantly altered in them. So your dose actually may need to be decreased. And response. Somebody brought up, well, what if a patient is tolerant to a particular drug, and if it's a true tolerance in which the receptors are just simply not as sensitive to the drug after a period of time, then you have to just increase the amount of drug. It depends upon the mechanism of the tolerance. But you would not, I'm not aware of any case where you would design a dosage form to treat those that are tolerant, because there would be too much danger of giving that to someone who is not tolerant and causing an overdose. But it's certainly a factor to take into account. So the response interaction of drug with the receptor depends upon structure. Right now, we need to make certain sufficient amount of drug gets to where we want it to go to see the response that we want. It would be better if we could somehow program the drug to go exactly where we want and only there. Minimize side effects, would minimize the amount of drug we would have to administer, etc. I've seen a lot of interesting things. One of the more intriguing ones that I saw a few years ago is join the drug with what amounts to some iron particles, and then took an external magnet and placed it over the area where you wanted the drug to migrate to and to collect. And then in that way, in other words, it magnetized it, so the drug then went to that particular area and stayed in that area. You can see some issues with that, but thought that was an intriguing way to try to target something. Now the targeting is more, well, what kind of cell are we trying to affect? So if we make part of the receptor that the drug is looking for the identity of these types of cells, so it will go and bind specifically to those and exert its effect. And there's a lot of research in that particular area right now. Hopefully, by the time you are well advanced into your career, there will be more of these types of drugs on the market. Little pharmacokinetics. This is the simplest pharmacokinetic model in which the body is looked at as a single compartment. And if drug is absorbed and distributed via passive diffusion, and there aren't any carrier-mediated processes involved, is descriptive of many agents. What can make it more complicated is, well, there's parts of the body that don't have the same kinetic signature, so you would add compartments. So it might be 2 compartments or 3 compartments. So right now we'll just deal with the simplest. So the simplest, and then we would define that in some way. Volume of distribution. Volume of distribution does not necessarily mean, in fact, it's not intended to mean biological volume. It is the apparent volume into which drug would distribute if the body was all one compartment. So a drug can have a volume of distribution. I mean, a standard volume on an individual of you guys, if you sort of took an average, would be somewhere around 45 or 50 liters would be your biological volume. But drugs would have a volume of distribution of 200 liters or 500 liters or something of that nature, or even 20 liters or 10 liters, depending upon where it distributes. The larger the number, the more widely outside of the blood system it distributes. The smaller the number, the more likely it kind of just stays in the bloodstream or some component thereof. So that's the volume of distribution. Its name is the apparent volume of distribution, but you tend to drop that. X sub t is the mass of drug in the body at time t. Concentration, C sub t, is the concentration. So these are related by volume. All right, take the mass in the body divided by the concentration in the body, that gives you the volume of distribution. Here is the overall one compartment equation that we've seen before. So C sub t is equal to C0 times e to the minus KET. This describes an IV bolus administration. So this is an intravascular administration where we put all of the drug into the bloodstream at one time. Logistically, that's really not physically possible. Usually takes 2 or 3 to 5 minutes to inject all of the sample, all of the drug into the blood. But considering what we can measure, there's no statistical difference between instantaneous and that. So this little squiggly line here shows the dose, X sub 0, is instantaneously put into the compartment and then distributes, and it can be described by this particular equation. First order elimination this way. The other route is with extravascular and absorption step. So Fx0, so this is the dose, and F is how much, what fraction of that dose gets in. There's an absorption step described by absorption rate constant, K sub A. And the equation describing that, you can see the format is similar to here. It's an exponential equation, but it's got 2 parts. This is the elimination part, and this is the absorption part.
Can you point that out again? I can't see that over here. Sorry. Which one's the absorption?
This is the absorption part, where's Ka.
Okay.
This is the elimination part. This is a constant that contains aspects of absorption and elimination. But since F, X0, and V are all constants, Ka and Ke are the absorption rate constant and the elimination rate constant specifically, this collection of constants you might just see represented by a single letter. A or B or something of that nature. Graphically, if you graph this information, this would be a y-intercept value. Just like that one is. Now, right now I'm not going to ask you to do any particular calculations with these, but wanted you to understand that these are these values here are termed pharmacokinetic parameters. These are parameters. And these we would estimate, and from this is how you would dose or continue dosing a drug. And it's these pieces of information that you would gather to help you to develop your drug delivery system to know how much drug to put into it. All right? We'll finish this up on Thursday.